professor, so I need to do a lot of stuff. The guy never says no to things like this. He's absolutely passionate about this work. He spoke at our hospice ball conference this year. Got a chance to know him a bit better, and he really is one of the great advocates of this work in the state. So please welcome the doctor.
Thank you. Give me just a second to find mine. Okay, I want to thank Judy and the TELP board for inviting me back. I thought that was especially brave since I spoke briefly last year. And I realize I'm the last thing between us and lunch, so they have chosen to try to provide some comedic relief to keep you awake. What I'm going to do is talk about what do we do when there isn't things to do. And I'm going to take sort of what I call the medical contrarians approach to ethics goals, CPR, and aggressive treatment. So feel free to interrupt me. I'm looking at the time so I know when to stop. And there we go. Okay. What we see is just because we can do a thing doesn't necessarily mean we should do a thing. This is actually out of the Journal of the AMA from November 13th. It talks about the care system, and Dr. Lynn, she was quoted earlier, says we provide disjointed specialty services, ignoring the challenges of living with disabilities, tolerate routine errors in medications and transitions, disdain individual preferences, and provide little support for paid or volunteer caregivers. This maladapted service system now generates about half of the lifetime cost for healthcare services, and yet patients and families are left fearful and disoriented with pain, comfort, and discomfort and distress. So that's a kind of a physician's review of our current healthcare system. Keep in mind that life is a terminal illness. We frequently tend to forget this. We work on the, I will make it out alive. But as Dr. Cunningham said earlier, we never say there's nothing else we can do. We can always find something else. It may just not be in the direction of curing the patient. As Hippocrates said a very long time ago, cure sometimes, treat often, comfort always. And that's the part where we really tend to fall apart. I can't tell you how many times as a hospice doctor I've come in to introduce myself to the patient in the room and say, I'm Dr. Phelps from hospice. Now the first really bad thing is when they go, hospice? I'm dying? The other one is, yeah, they told me there was nothing else to do. And I'm like, no, there's a whole lot more we can do. I routinely come in to give talks to nursing homes and other staffs, and I say, I'm Dr. Phelps, I'm from hospice, I've got morphine, who would you like me to kill? And there's this nervous titter that goes through the room, just like this one. And I say, I knew you were thinking it, we're going to talk about it, because what we're really about is what's the best quality of life that you can have. So, just in case you were thinking about running for the door, things I'm going to tell you about. You know what they say, a good lecturer will tell you what they're going to tell you what they said, and then tell you what they told you. We're not as good as we think we are as doctors. We're going to look at the role of screening in the elderly and terminal. We're going to look at benefit versus burden of treatment, look at number needed to treat, peg tubes, time to benefit, and discuss the impact of polypharmacy, and what do patients think about this and the role of patient-centered care. So that's just kind of things we're going to kind of talk through. Since I mentioned ethics, I want to say that we do try to do the things we do because we're trying to do the right things. These are the four cardinal virtues. The cardino from Latin is the hinge on which our lives turn. They're biblical virtues. There are other virtues, but prudence, justice, temperance or restraint, and fortitude were the ones that St. Thomas Aquinas adapted, and since we're in St. Thomas Hospital, that seemed appropriate. I think it's a different Thomas, though. Bioethical core principles first came out in 1979. Now, that's kind of a scary thought that they came out with those principles in 1979, because that's the year I graduated from medical school, and so they were not really known. So this is really, the whole bioethics field is relatively new, and they were autonomy, beneficence, and justice, and later they added in human dignity and non-maleficence, which is we don't do bad things to people. We aim for their good, and we're trying to do justice to people. And finally, the autonomy. And what we frequently see is that autonomy has kind of become, the tail that wags the dog for everything. I also wanted to mention, and much like Dr. Cunningham, I am a bibliophile. If there was a specialty called bibliotherapy, I would be its practitioner. I have lots of books to talk about. But I wanted to mention a word or two about what utilitarian ethics. And this is a book that came out recently called "Would You Kill the Fat Man?" And the premise is that you're standing over a narrow valley looking down at some trolley tracks, and you see, oddly enough, 5 people tied to the tracks down the way. Now you look up the other way and you see a trolley, a smallish train, coming down the tracks. It's loose. And then you just happen to notice, because this is in the book, that there's an overpass with an exceptionally fat man on top of it. And you happen to know that if the fat man were to land on the tracks in front of the trolley, it would stop and save the other 5 people. So that's where the question is, do you kill the fat man? And they have a variety of ways of setting up the scenario of would you or won't you? But, and this is a fun book to read. But one of the things they talked about was St. Thomas Aquinas, who before he was sainted, he wanted to go into the monastery, and his family didn't think much of this, so they locked him in a castle with a prostitute. Apparently it didn't shake his resolve, because he subsequently made saint anyway. But they have a long discussion about the doctrine of double effect, which is you do a good thing, but a bad thing might come out of it. In this case, and in hospice's case, we're treating pain. And I, as a hospice doctor, I've been asked several times for physician-assisted suicide, including by my mother, and said, no, this is we can do effective pain and symptom management. And given that you have a terminal diagnosis with less than a week or so to live, I'm not going to go to jail for you. Twin effects of the actions, one aimed at, the other not, but it's foreseen but not intended. The act is considered independently of its harmful effects. The agent does not intend to do good and does not intend the harm either, and there's no way to achieve the good thing without possibly causing the harmful effects. And where this comes in all the time for us is in treating pain. And I've had this discussion with our patients who've asked about, can you just go ahead and kill me? And I said, no, but I can give you pain medicine until you either are not in pain or stop breathing. And that is considered both morally and legally appropriate. And I have actually done that on 1 or 2 occasions. We had one poor patient, and we were giving hundreds and hundreds of milligrams of morphine IV by a PCA pump, and then we're giving additional morphine. And the patient kept saying, no, it's not working, no, it's not working, no, it's not working. And the nurse and I were sitting there going, squirt, how now? Squirt, how about now? Squirt, how about now? And finally she said, literally while she was talking, she said, oh, thank God, finally I am not hurting. And while she was talking, she died. That did not mean that she died of an overdose. It meant that we got her pain under control. I'm not sure what the metaphysical construct is, but I have seen people in so much pain that they could not die until you relieve their pain. I'm hearing some mm-hms back there, so that must not be unique to me. I talked about patient autonomy. Back in 1891, the Supreme Court said no right is held more sacred or more carefully guarded by the common law than the right of every individual to the possession and control of their own person. However, medicine has remained, or what did remain, pretty patriarchal, and I use that word deliberately as opposed to parental, because up till then it was mostly a male-dominated profession until the 1970s. I remember a friend of mine's brother saying when he was in the hospital, what was my blood pressure? And the nurse said, we're not allowed to share that information with you. That's for the doctor to know. So I've kind of lived through that change, but that's where we were was shut up and do what I tell you. In the 70s and 80s, we began to see a shift. Families particularly began to ask for non-beneficial life-sustaining treatment to be discontinued. We've all heard of Karen Ann Quinlan, Nancy Cruzan, and most recently Terry Schiavo, where court fights ensued. But now we're seeing a new shift, which is what should we do when the physician believes that continuing patient's treatment will not benefit or cure the patient, and the patient's family disagrees with the physician's determination about futile or non-beneficial care. Now we're going to come up on the poster child, and this one's ongoing right now in creating this medical monster. Why are we seeing this now? And I've seen doctors say, I'm just there to do what the patient tells me to. And I, as a medical director for a hospital system, I would talk to the one particular doctor that sticks in my mind and say, why did you do that? And he said, they asked me to. I said, but it wasn't appropriate. But they asked me to. Patient autonomy. I said, no, it doesn't quite work that way. So we've created this medical monster. We don't want to talk about death. We don't want to talk about aging. We don't want to talk about disease. Frequently, and we've all heard about the death panels and all that stuff, it is more cost effective for the doctor, the family, and the hospital not to discuss end-of-life care. If you get paid to do a certain thing and you don't get paid and have a very painful conversation about why you might not do something, guess what happens? Somebody won the Nobel Prize in the mid-1990s for figuring out people will do what you pay them to do. If you pay them to do one thing and you don't pay them to do another, guess what happens? Also, pharmaceutical industry is the single biggest spender. I looked this up last week just to make sure I was still giving the correct information. Single biggest spender of lobbying in Washington, followed by the insurance companies. I know you're all shocked. And the media creates myths that all problems can be solved with pills or procedures. I think direct-to-consumer advertising has been one of the biggest messes that we have seen. I don't have a cartoon for it, but there's in the New Yorker it said, and you know, if you think that taking a pill to resolve all of your problems would be appropriate, contact your doctor about this pill. So, this is our poster child right now. This is a very sad case that is ongoing, or actually it's over, but they just don't acknowledge it. Very sad case where a child had a tonsillectomy. She sounded from the description that she had a sleep apnea problem. She had complications from it, and so, quite honestly, she died post-surgically. The first neurologist said she's brain dead. The second neurologist said she's brain dead. The third neurologist said she's brain dead. And a death certificate has been issued, and the patient's attorney has said that the medical team wants to feed her so her brain will have optimum nutrients, and she was eventually discharged from the hospital. As I mentioned, a death certificate was issued, but she continues on, quote, life support for this person who's been ruled dead by a number of authorities, and she was moved. Apparently there's a Terry Schiavo, you heard that name before, fund that has moved this child to another facility outside of the children's hospital where they litigated to eventually be able to release the body. So I just want to say a problem with miracles. You heard me say I do have a degree in theology, but sometimes we do have problems with miracles. Families will not engage. You heard earlier about somebody saying, no, if I talk about the possibility I could die, I'm entertaining it, then God will let me die because I lost faith. I have lots of conversations, and one of the things I love about working in hospice, I have 4 chaplains to irritate. And said, how do you, when they say, the family tells me that if we pray hard enough and we work hard enough, this person will die and then they die, how do they reconcile that? And our senior chaplain, who's been doing this for like 30 years, goes, you know, it's really weird. They just kind of like all of a sudden have this sudden mental shift that it was, well, you know, I guess it was meant to be after all, as opposed to, well, they must have been an evil person and we just didn't know it, which is where I would have gone. So if they die, does that mean their faith was not strong enough, or God doesn't answer prayers? Miracles are called that. And this is kind of my language when they say they're praying for a miracle. Usually I'll say, well, we're going to hope for the best. And I say, I love miracles. I'm very happy when they happen. They're just really rare. They violate the laws of nature, physics, biology as we understand them. Do they happen? Yes. Do we understand them? No. But that's why they're rare. That's why they're called miracles as opposed to stuff happens. And death comes to us all. Now, when you're talking pediatrics, this is not an argument you really want to go down, but I've had 80-year-olds go, so I can't die, I'm too young. And I literally kind of almost burst out laughing and said, well, what would be an appropriate age to go? And the short answer is, not mine. Oops. So, some ethical collision caveats. Professional autonomy allows that the provider is not obligated to provide care that is clearly non-beneficial. So, a physician says the patient told me and they've got autonomy does not mean that they have an absolute right to dictate care. Autonomy is considered to be more powerful to refuse care than demand care, and some of this touches on social justice. That I can't demand that you do a heart-lung transplant on me when you don't think it's appropriate. Where I might say, no, I don't want to I don't want to be a DNR. And social or distributive justice, I mean, there's stuff in the newspaper. Actually, the front lead article in the New York Times this morning, it was about Obamacare. I mean, we can't afford to continue the system we've got, and this is going to become a bigger and bigger issue. So, Survey of the California Health Foundation found 70 to 90% of patients would prefer to die at home. Only about 30% do. 66 said they would prefer to die of a natural and peaceful death, and only 7% desire all invasive therapeutic options considered. I will tell you that families are usually much more aggressive about this because they haven't lived through being sick and sore and just miserable for periods of time, and they're still do everything. That's one of my problems sometimes with advanced directives that designate a surrogate, because I've seen surrogates. We actually did an ethics what-if case, and the next week it actually happened, where as soon as the patient lost their ability to make decisions, the family said, no, we want everything, where the patient had been consistently saying they just wanted comfort care. AMA reports are that the 80% of patients surveyed feel it's important to have advanced directives, but only 24% of them have done them. So communication at the end of life. Hey, Gramps' deathbed, one word or two. That's kind of like, I'm Dr. Phelps from hospice. End-of-life discussions. This is in the Journal of the American Medical Association, a survey of 332 patients with a terminal cancer, stage 4 by definition. Life expectancy in that study was or life duration was 4.4 months. It said, have you and your doctor discussed any particular wishes you would have about the care you would receive if you were dying? Not a theoretical construct. These people really were dying. Only 123 or 37% did. Why? Once again, going back to what Dr. Cunningham was saying, they said, well, we didn't want to destroy hope, we didn't want to cause depression, we didn't want to make them, feel bad. Actually, the patients adopted less aggressive care, fewer ICU admits, less episodes of ventilation, and if they took less aggressive care, much like the palliative care versus oncologic or regular oncologic care in the lung cancer study, patients who did less aggressive care had a better quality of life, and their families were less stressed, and if they got a very aggressive care, the families were at risk for PTSD and depression afterwards. Another study from the Center for the Advancement of Palliative Care on survey of attitudes. Physicians not providing all treatment options, doctors not sharing information, all of these are more than 50%. Doctors don't spend enough time talking and listening. I think we've heard some about communication, but that's kind of disturbing since the word doctere from Latin means to teach, that half our patients or more feel we don't spend enough time talking with them. And the one that really bothers me is the one sort of in the middle, patient and family leave the doctor's office not knowing what they're supposed to do more than half the time when they get home. This is more recent. Institute of Medicine's study on cancer just came out in September of this year, and it's patients want involvement. What do they want? First thing, listen to me. Tell me the full truth about my diagnosis, even though it may be unpleasant. Tell me about the risks associated with each option, and all the way down to offer options that he or she feel might be right for me. So this is what patients want, and this is unfortunately not what they're getting, but the Institute of Medicine is trying to push them along to having more of these conversations. Goal number 1, engaged patients. The cancer team, and I'm not picking on cancer, this just was what was in the report, should provide patients and their family with understandable information about cancer prognosis, treatment benefits and harms, palliative care, psychosocial support, estimates of the total and out-of-pocket costs. Diagnosis of cancer, right there, your chances of declaring bankruptcy double the day you are diagnosed with cancer. I give patients lists of questions when they're frequently in palliative care and they're going back to see an oncologist, and I say, ask them the questions like, what percent of your patients have recovered from this? What is your 5-year survival with these things? How sick is this going to make me? And in your experience, and that's always, oh, I couldn't ask them those kind of questions. So you're the one's going to live through it if you don't. So they're pushing it. So we're going to change gears slightly. Hospitals can be dangerous to the elderly and others. It says fill out this toe tag and attach it to your toe. Now, the really sad part of this is I've been a hospital medical director, and I still think this is probably true. Now, I said I was going to tell you we're not as good as we would like to think we are. This is out of the British Medical Journal, June 2010. Doctors in Israel on strike. What they found was the death rate went down substantially while the doctors were on strike. They canceled hundreds of thousands of clinic visits, tens of thousands of elective surgery. The result, deaths fell from 153 to 93 that month. That was replicated all across the country. And said one expert, yeah, we saw the same thing in 1984. The one hospital with a no-strike clause had exactly the same number of deaths. It was the only one that didn't fall off. So I always kind of look at that and go, yeah, we may not be doing quite as much as we'd like to think we are. Going back to my toe tag cartoon, hospital-associated debility. If you put an elderly person in the hospital, they don't do well. In 1/3 of patients who are hospitalized over the age of 70, 1/3 of them will lose an activity of daily living. If you get to over 85, 50% leave with a new disability. And 1/3 of patients who are hospitalized have delirium, most commonly hypoactive delirium. Nurses in hospitals love these patients. We've all heard of the O sign. They just lay there and they go. They don't bother anybody, they don't hit the button. Now, hyperactive delirious patients are trying to climb over the rails, everybody knows who they are. That's actually not as bad as hypoactive delirium. And this has bad prognostic indications. 81% of the elderly who developed a hospital-acquired disability died in under a year, and another 29% of that, 58% still were disabled 1 year after the fact. So this is not a benign thing to do, and hospitals may not be the appropriate thing. So I'm going to talk a little bit about, we talk about slow food and locavore. We need to talk about kind of slow medicine, and maybe we don't do quite as much for some of our frail elderly. Steps to avoid hospital-associated disability: avoid one-point restraints, urinary catheters, IVs, O2, NG tubes, all the things that hold patients down. As a hospital medical director, I used to make case management rounds with our director of case management, and she'd walk down the hall going, she hadn't been out of bed, she hadn't been out of bed, he hadn't been out of bed. And of course, what happens is they come in with the pneumonia. They say, the nurse comes by and says, hey, I'm supposed to walk you, and she says, oh, honey, I just don't feel like it, and I've got this catheter, I've got this thing in my bladder. Could you come back later? And the nurse is thrilled because then they don't have to do it. And so the patient does that all 3 shifts, for the entire time they're in the hospital. Then we get ready to send them home, and we put them in the wheelchair, wheel them out to the car, and this is the first time they stood up unassisted. They stand up and fall down and break something. Better recognition of functional status, and sometimes this has to be show me. If you ask patients, how are you doing before? I was doing fine. Could you walk? Yeah. Could you talk? Yeah. I had one patient I went out to see for hospice, and I was doing his recertification that he was sick enough to stay in hospice. And I said, he was sitting on the couch, and he was elderly. He was in a cabin way up in the mountains. And I said, so, how are you doing? He said, oh, I'm doing good. Patients want to tell doctors they're doing, that your treatments are working, I'm feeling better. And I've literally, in some patients for hospice, said, do not tell me you are doing better, because I will kick you out. So now, we're going to talk about how you're doing. So I would say, so how's you doing? Are you walking? Yeah. So, were you getting out of the house? And he's, yeah. So you going into downtown Gatlinburg? Yeah. So when'd you last go? About a week ago. So I'm like, holy crap, I'm going to have to kick him out. Well, once again, same chaplain said, did you see him walk? I'd only been with hospice about a week. I said, well, no, nobody told me he did. He said, just see him get to the car? And I said, no. He said, that guy hadn't been off the couch in 3 months since I've been following him. I said, oh. Well, why would he tell me that? He said, he wanted you to feel better. I said, well, he almost got kicked out of hospice. Walk and exercise patients if at all possible, ensure they're eating properly. I was actually over here in Nashville having heart surgery about 1.5 years ago, and you can tell I like to eat, and I lost weight while I was in the hospital. Hospital food's nasty stuff. They put you on a low-salt cardiac diet, and you really don't want to eat that. Avoid sedative hypnotics, antihistamines, recognize and palliate pain and symptoms. All of these, there are some hospitals now that have specialized geriatric units, which almost seems like an oxymoron, because most people in the hospital are geriatric patients. But to try to do this assessment and make sure that these patients don't lose function while they're in the hospital. Oops. Why do they get frail? They lose muscle strength, they have poor sleep, they get more easily fatigued, they may have poor cognition, decreased balance, poor motor processing, and just general frailty is associated with 300 to 500 increased risk of mortality. Why do they get it? You lose muscle mass, you get neuroendocrine dysfunction, low testosterone, low estrogen, a low insulin growth factor, and then low-grade chronic inflammation all appear to play part of this, according to the American Geriatric Society. So we talked a little bit about triggers, so I won't belabor this much. I like the surprise question, and you'll notice it's in mine too. If they're bouncing back a lot, they have complex care requirements. When I go out to make my hospice face-to-face visits, I look for the oxygen sign on the front door. Warning, do not smoke when walking into this house. Because that's how I find the houses. I get the address, and sometimes there's a number on the house, and sometimes there's not. So I'll take my little car, I have a little tiny red Hyundai, and I kind of back up and down the street looking for the oxygen sign. That 9 times out of 10 will get me to where I want to be. If they're on oxygen at home, they're not well people. Coming in or out of ICU, you're going to initiate dialysis or ventilation. PEG tube is contemplated. Pain or symptom management. My wife is a GI nurse at a hospital in Knoxville, and there's not a week that goes by that they put in a PEG tube in a geriatric patient who's forgotten how to swallow, which ought to be a hint. And she goes, "Oh man, I wish you could have talked to this one." So these are things to think about. Maybe what we're doing isn't what we ought to be doing. In curative care, let's see if I got a laser here. Yes. Object treatments of the disease. We put primary value in labs and x-rays. Patient's body is differentiated from their mind. Therapy is indicated to cure the disease or slow the progression. Death is the ultimate failure. Over here, comfort care, palliative care. Primary value is the patient's experience of suffering. We're viewing the patient as complex beings with emotional, psychic, social, and spiritual concerns. Therapy is indicated if it helps relieve their symptoms and enabling the patient to live fully and comfortably until he or she dies a success. Those two we're pretty good with. The one in the middle, functional status for the elderly, maintaining, improving function, and keeping them functioning, and therapy is scaled to what the patient can tolerate. Case in the New England Journal of Medicine a while back said, it was kind of we could do it this way or we could do it that way. I don't know if you ever saw the movie Sliding Doors or Sliding Glass Doors, and had Gwyneth Paltrow in it. The whole movie was premised on she makes it through the doors and gets on the train, or she doesn't make it through the doors, and what happens. When you have a patient, and in the New England Journal article, they said, patients in the nursing home, it's 2 in the morning, she runs a low-grade fever of 100. The nurse calls the doctor, who of course is not the doctor who cares for the patient, knows nothing about them, and says, well, take him to the emergency room. I don't know about here in Nashville, but in Knoxville, every PCP's office, if you call after hours, says, if you have a medical emergency, call 911. So they send to the emergency room. The emergency room looks and goes, it's 100, get a chest x-ray, it shows a little bit of atelectasis. If I send them back, they'll bounce back again, so I'm going to call it pneumonia, put an IV in, run at a certain rate, and give them IV antibiotics. The following night, because the patient was up all the first night, they climb over the bed rails and fall and break their hip. Tens and tens of thousands of dollars later, they eventually make it back to the nursing home, and they are worse off than they were before. Versus the nurse calls and has a nurse practitioner, for example, who comes out, listens to the patient, goes, maybe a little something, we'll give them some oral antibiotics, and we'll keep them in the nursing home, no harm, no foul. And so once again, it's kind of what happens at that critical juncture. PO antibiotics may not have been the best and the greatest, but it was certainly, for that patient who didn't get a broken hip as a result, was an improvement over the care. We were having an ethics discussion at UT, and we had a medical resident. I love residents because they're really kind of, it's beaten into them. There is one way to do the right thing, and they don't kind of know where the box is to think outside it yet. And we had this resident pounding the desk saying, the only way to do this is to do this, and if they don't like it, it's my way or the highway, and they need to go because we are not going to compromise on this. And I'm going, yeah, okay. Sometimes you gotta put your money where you think it needs to be, and this is a discussion. And I've told patients, well, it might be a little bit if we did this, but we'll avoid all this. And I, without talking about the cartoon, I say, hospitals are dangerous places. We grow really big bad bugs there. Maybe if we can try this at home before we go to the hospital, maybe we'll do just as well. As we get older, we get more stuff. 68% of chronically ill patients have more than 4 chronic conditions. Those who live past the age of 65, which I am not far from, have an average of 3 years of self-care disability at the end of life. So we need to be thinking about when is it we change looking at that trigger tool to is when we want to reorient our efforts. Everyone is entitled to some palliative care. It is not, well, you go right up to the end and bang, oh, we're doing palliative care, there's nothing else we can do, and bang, you're in hospice and then you're dead. It ought to be just a little bit at the outset where we're talking about quality of life and then versus quantity of life. There is, as we've heard, it's not necessarily mutually exclusive. There is good data to say people in hospice with a specific illness live longer than those without it. Heart failure has a 3-month survival advantage. That was a drug. I mean, Provenge, which gives 1 month of additional life on the average prostate cancer patient, is $30,000. If 3 months for being in hospice, if we could bottle and sell that, I could make some money. So where does do everything apply clinically? This was in last week's New Yorker. It says, I'm sending you to someone who's less squeamish. CPR, A&D is allow natural death, DNAR, do not attempt resuscitation, DNR. This is out of a review of in the New England Journal. The low rate of success in CPR may be an example of how a medical myth is perpetuated by the media because it's much more appealing than the truth. Somebody did a study, it was in the New England Journal. Success rate in CPR was 65 to 100%. The show to die on is Rescue 911, they didn't lose a soul. Actual CPR. And this is why you can't have this conversation in 10 minutes, as you've heard several times. Success in the hospital, rates range from, and I've got a pile of articles yay thick. Success ranges from 13 to 20% in a healthy, normal person. 15% is probably good. That's a healthy, middle-aged person having a cardiac arrest. That's me standing on the stage hitting the floor. And yes, I do want CPR. Out-of-hospital rates, 10% or less. CPR is less age-dependent than illness-dependent, but when you get past 80, your chances of surviving CPR are only 3%. Overall 15, frail elderly goes down from there. That should be about 6%. Advanced chronic illness, metastatic cancer, multi-organ failure. In bed more than half of waking hours. That'd be an ECOG score of 3 or higher, 0 to 3%. A review, this is interesting, I'm going to come back a couple times to the number needed to treat.org, which is a group of doctors that look at the data, said they saw no benefit to ACLS medications, although defibrillation did seem to be helpful. And they do risk-benefit for a variety of different clinical things. And it's really kind of, even as a family doctor practicing for 30 years, I was rummaging through there over the last couple of weeks and going, oh, I didn't know that. Oh, I didn't know that. Because once again, the pharmaceutical companies are out there selling stuff, and they make money by selling stuff, not by not selling stuff. I am not making this up. Years ago, I had a pharmaceutical rep. I said, he was showing me the numbers, and I said, so is this statistically significant? And he said, doctor, it is numerically significant. And I said, oh, okay. I'm not quite sure how that's different. I am now, but I wasn't then. CPR injuries, 30% rib fractures, brain injury. Of the 18 to 20% that survived in one study, only 58% were still alive 1 year later. However, of that half had moderate to severe neurologic injury, and 60% of those people, of that 58%, were now in a nursing home from their neurologic injury. Additional injuries, pneumothorax, perforation of organs, lacerations to internal organs. So CPR is not a benign thing. And one article I read said, they were talking about how many people want to die of CPR. No hands showing, just like there are none here. So this is another book, Nudge. This is about choice architecture or decision architecture. Designing systems where all options remain, but the best choice is the most obvious. And they talk about things like putting the healthy food at eye level and putting the lard-based chips down at foot level, so you have to bend over to pick up the stuff that's really bad for you. They talked about 401ks. The company came to these guys, these are economists, and said, this is free money. We've got a 401k and nobody will sign up. And they said, well, how do you do it? And they came out and said, well, we give them this stack of papers and they fill it out and they sign up and and they're in. And he said, do the opposite. Tell them they're in, and they'd have to fill that stack of papers out to get out if they want their money. So the choices are still there, but you've made it more difficult to get out than to stay in. Their rate went from 5% to 95%. So it's frequently how you do it. So as opposed to, and we've heard a little bit about, hey, you're in the hospital, while your dad's here, if his heart stops, do you want us to restart it? Yeah. If while your dad's here and he's dying of lung cancer and the time comes, do you want us to allow a natural and peaceful death? Same answer, yeah. So how you phrase the question makes a difference. And somebody did a study, it was a 20% shift depending on how you asked. And families, and you made this point, families don't want to be asked to let their loved one die. Here, we're going to take something away, we're going to not do resuscitation. So I like the not saying you're just signing the form saying that we had the discussion. You're not saying that you want this to happen. The other thing is kind of pushing back the pendulum a little bit we went from patriarchal to we're just your monkey, tell us what to do, to being the content expert and saying in this case we don't think that resuscitation will do any good for the following reasons, and my recommendation in the order I'm writing is that we're going to allow a natural and peaceful death when that time comes. And then if the family pushes back, then you can have an additional conversation about it. But asking somebody, hey, would you sign this thing letting your mom die, can be a tough thing. So the question is, how do we ethically do it in such a way that we get the right result for what is clinically indicated? The patient is the expert on the patient, but we are the expert in the care. And we've sort of abdicated that role in some cases. Let's see. Education shows that they did a study of 371 seniors over the age of 60. 41% wanted CPR. After education, about the survival odds, that dropped to about 22%. So, a lot of times people don't know, and there are now commercially available videos, and we're talking about doing one in Knoxville that says basically this is how it works, this is what it looks like, and these are your odds of success. And there are a couple articles out there saying when people see these, they make fairly substantial changes in how many of them want it. Medical screening. 45% of physicians said they would screen a 50-year-old with unresectable lung cancer. 37% they do a 65-year-old, and 25% they do an 80-year-old with unresectable lung cancer. This was in JerryPal, which was reporting the article. Actual screening in cancer patients, mammography among patients with advanced cancer was 9%, but that's only half of 22% without cancer. Pap smears, 6% versus 13%. PSA screening, 15 versus 27%. Colonoscopy, 2% versus 5%. So roughly half the people who already have a pre-existing terminal illness are continuing to get screened for another terminal illness. Another study looking at Alzheimer's found 18% of severe Alzheimer's with a life expectancy of 3.3 years had a mammogram in the last 2 years. Screening to treating. Survey in JAMA Internal Medicine found half of patients would not have a screening test if the test resulted in one person being overtreated to avoid one cancer death. Fact is, in 1,000 50-year-old women screened for a decade, between 490 and 670 women will have at least one positive false alarm. Of these 1,000, 0 to 3 cancer deaths will be averted versus 3 to 14 overdiagnosed and treated needlessly patients. The screening that we do, there is some effect to it, but not a whole lot. But it's kind of a talisman of, I can't die from breast cancer if I've had a mammogram. Likewise with PSA screening, if you go to the number needed to treat, they rate them in green, this is a good idea, to red, really doesn't matter because it's not going to help, to black, which is this is a bad idea. Number needed to treat gave PSA screening a black rating, meaning it was more harmful to screen because of the 20% of people who would get a false positive and get a biopsy and have pain and suffering, not to mention possibility of infection from that. So why do we continue screening? The American Cancer Society says it doesn't recommend cancer screening for patients with a life expectancy of under 5 years. But doctors get grades based on their screening scores. They get bonuses based on their quality scores. They don't want to have the hard conversation. If they come and say, it's time for mom's mammogram, you can either A, say, sure, here you go. Or you can say, well, mom's 94 now, and it's probably isn't going to do a whole lot for her. So, once again, you get paid to do what you do. Going to talk a moment about medications. There's the Beers list. Group of geriatricians under Dr. Beers, it's no happy hour, came up with a list of medications to give the elderly only with additional forethought. In 1999, CMS incorporated the Beers list into nursing home regulations. There's a variety of medications we commonly use. They just updated the Beers list. I printed off, it was like 20-something pages, single-spaced, of medications you ought to think hard about giving to the elderly. The average patient coming into hospice is probably easily on 15 medications. The chances of a drug-drug interaction are 99.99% when you get to around 8 medications. We end up treating a medication interaction with another medication. I love geriatricians because they see their job as the anti-drug people. They will say, bring everything in your cabinets, and then they pull up very ostentatiously, because I've done this before, a large trash can and go, nope, 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 nope. Cancer treatment. This is from the American Society of Clinical Oncologists and National Comprehensive Cancer Network. First thing, doctors and patients need to have more realistic expectations. I had a patient who ended up in our hospice who said, I had to change oncologists because I said, what are my chances here? And so, oh, they're good, you know, we can beat this. And he said, no, I mean, numbers, how many patients who've had this are still alive in 5 years? And he said, oh, you know, we can beat this. I said, my case, this number. And he said, we can beat this. And he said, I had to change doctors. I wanted somebody who's going to actually engage me, not just, just blow happy smoke at me. Target surveillance or imaging to circumstances where the benefit is demonstrated, which is not in cancer of the pancreas, ovary, or lung. So if you've had cancer of the pancreas and you're getting serial CT scans every 6 months to see if it's coming back, it's not making you live any longer. It's actually probably shortening your life. As I've had to do education with radiologists, say every CT scan is a 1 in 2,000 chance of inducing a fatal cancer. And that was, when I sat down with our Department of Radiology and went through that, they were like, oh. I've seen people who went from one hospital because they had a headache, they got a CAT scan, they showed up at the other hospital, and then they got another CAT scan the same day because they didn't want to go to the trouble of calling somebody else, and of course they make money making the CT scan. Limit second and third line chemotherapies to single agents. There was only a small benefit, and this is in solid tumors, to combined therapies. Limit chemotherapy to patients who have good performance status, except in highly responsive things. This is patients with an ECOG score of 3 or better. Don't kill them, don't try to kill them, and then use colony stimulating factors to try to get them back. And after 3 successive rounds or cycles of chemotherapy, any additional chemotherapy should be limited to clinical trials if they're well enough to do it. If the choice 1, choice 2, and choice 3 didn't do it, choices 4, 5, and 6 are probably not going to do it either. Better integrate palliative care into usual oncologic care. And now the recommendation is that the palliative care be instituted when metastatic cancer is diagnosed or significant tumor burden is discovered. So even in cancer, there's, we should be being a little more realistic about what we're doing. The NQF and ASCO came out with quality measures. I made myself fairly unpopular on our cancer committee when I suggested we do some of these. Proportion of patients receiving chemotherapy in the last 14 days of life, less is better, but 20% of patients are still getting chemo within 14 days. Proportion of patients with more than 1 ER visit, less is better. Patients going to the ICU, patients not admitted to hospice, patients in hospice for less than 3 days. That they have a plan for treating their pain and that their pain intensity is quantified. Pill burden. This is a true story. I got a call from our chief medical officer at UT Medical Center. He said, I just wanted to know you had a complaint from a patient's family. I said, really? Me? And they said, because we all know I was the world's greatest doctor. And they said, he said, yeah, they wanted to complain to you for patient neglect. And I said, oh, and he told me who the patient was. Well, the issue was the patient was dying of esophageal cancer. The daughter called me from the West Coast and said, hey, when should we come? And I said, now would be good. Now would be very good. She said, well, we're thinking we'll drive over in the next couple of days. And I said, I would get on a plane and come now if you want to see your father alive. Yeah, okay, well, we're going to start driving in a day or so. So, of course, he was deceased by the time they got there. In the meantime, because of his cancer, he was having increased difficulty swallowing, and the family member, the child who was actually caring for the family member said, what are these pills, because we're really having a hard time, can we drop out? And I said, well, the first one would be the statin he's on, because I really don't think he's going to die of heart failure or heart disease before this gets him. So that was what the complaint was medical neglect, that we stopped the statin on a patient who was dying of esophageal cancer in 3 days. So Many illnesses are treated by the primary care doctor are illnesses of the 21st century. As patients get cancer or other chronic illnesses, they tend to lose weight. Their blood pressure gets better. Their cholesterol gets better, and we'll talk a little bit more about that in a minute. Their sugars get better. I had one poor lady, she had a blood pressure. I went by and took it. It was 80/50. I said, "You get dizzy when you stand up?" And she said, I pass out when I stand up. I said, "Are you on any blood pressure medicine?" She pulled out 4 different bottles. I said, "Okay, 2 are done. We're going to start whittling down from there." So patients die not of TB, malaria, or starvation. They die of disease, stroke, cancer, Alzheimer's. But the prevailing medical model is built on the acute concept of acute illness, where the prevailing epidemiology is more of one of chronic illness and risk management. So we look at diabetes, hyperlipidemia, hypertension, osteoporosis, and these medicines don't work as well, and I'm going to give you a quick tour of that. Number needed to treat. How many people do you have to give this to prevent something? Primary prevention for vertebral fracture, 50 people have to take this pill for one of them not to have a vertebral fracture. If they've had a vertebral fracture, then you're down to 1 in 16 will not have another one. Cholesterol and statins, primary prevention, 60 people have to take this pill. 4 or 5 years for one person to avoid a heart attack. And 2% of these patients were harmed by developing diabetes, and another 10% had muscle damage. And I've had a number of patients say, "Man, I just can't take that stuff. I just ache all over when I take it." Stroke or warfarin, number needed to treat 25 to prevent 1 stroke. When patients come into hospice, we kind of routinely take them off of warfarin. I said, "You have a 6-month prognosis at this point. The chances of you falling and hitting your head, if they're frail, is considerably higher than you having a stroke, which is about 4%, maybe a little bit more from your atrial fib." Alzheimer's disease. I almost got in a fight with a neurologist, and I were on a panel with the Alzheimer's Association, and I was politely not saying anything because I was an invited guest, and one of my palliative care colleagues in the audience said, "So what do you think about how well these medicines work?" I'm like, Okay, so this is a PET scan of patient with Alzheimer's disease here, showing up the plaque, less plaque, less plaque. Medicare has decided they will not pay for this scan, which is largely diagnostic, because they said it doesn't really change anything. There are no real effective medications, and it doesn't improve the outcomes for Medicare beneficiaries. Oddly enough, the Alzheimer's Association and Eli Lilly, who'd given the Alzheimer's Association $1.6 million, both objected to this finding. So with that, these are a couple of articles and comments. In general, Alzheimer's medication is a relatively low benefit for a decidedly small percent of population. Estimates are that you need to treat between 3 and 7 patients for modest benefit of perhaps 1 to 2 points on a mini mental status score, which goes up to 30. Most statisticians recommend a 10% improvement. Even then, the patients will begin losing ground if they happen to be one of the few that improves. And the anticholinesterase are only indicated for mild to moderate Alzheimer's, and I get lots of severe Alzheimer's that are even worse. Let's see, 18 months to 3 years at the very outside. However, patients are desperate to try these medicines, and many experts will recommend a trial for 3 months and then retest. I can't tell you how many patients I've seen that have gotten on these medicines and are on them years later. What the medicines don't do, this is from Consumer's Guide, this is even a medical journal. Medications used to treat Alzheimer's are not particularly effective. When compared with placebo, most people will not experience meaningful benefit, and it's the rare person who has significant delay in symptoms. Again, combining Aricept and Namenda, we see this all the time in our IDG meetings. I take people off of these. They're on Aricept and Namenda, although common, is no more effective than either medicine by itself. That's out of the New England Journal. What else do they not do? They don't help with agitation more than placebo. And Namenda was not statistically significant in showing, does show significant, statistically significant slowing in Alzheimer's, but the change is minimal. And I've got the statistics there for that. When Aricept lost its patent, they came out with Aricept 23. And this made both the New York Times and the British Medical Journal because it was no more effective and considerably more expensive, and it had a lot more side effects. And they were saying this was a pure case of greed over clinical care. Blood pressure, it takes years to develop for illnesses related to high blood pressure, though African Americans seem more vulnerable in treatment of blood pressure without previous cardiovascular diseases. If for mild to moderate blood pressure did not show any changes in treated and untreated individuals. This is out of the Cochrane Reviews, which does the meta-analysis of the data. And they did a study of should you have a lower blood pressure if you have diabetes. 4 of the 5 studies were funded by drug makers. They showed a tiny reduction in stroke, but a substantial increase in serious adverse events. Feeding tubes and the dementia death tube spiral. And if you go to Fast Facts, you'll find this scenario. Repeat admissions for severely demented from nursing home patients. The patient resists feeding, chokes, gags a little. Nurses suggest a swallowing study. They get a swallowing study that shows, surprise, aspiration. GI is consulted for a PEG tube. This is my wife's nightmare. To improve nutrition and reduce aspiration, tube is placed, patient returns to the nursing home, pulls the tube out, gets restrained, puts it back, gets pneumonia, repeat, repeat, repeat. Finally, you have a family conference, and then the patient dies. Let's see, out of evidence of care at the close of life, 51% of advanced Alzheimer's patients will refuse food. There is an inability to maintain nutrition orally in the face of chronic life-limiting illness. It is usually a marker of the dying process. If you are so demented you can't remember to eat. Factors independent for getting a feeding tube include a speech therapist on full time, larger facility, more Medicaid, fewer assistants. Nursing homes receive a higher reimbursement for tube-fed patients. They do not, and I've been an expert witness in court on this, where they wanted to put a feeding tube in somebody. They do not prevent aspiration. They do not improve function or quality of life. They do not improve comfort if you've got something stuck through your nose or stuck in your abdomen. They do not usually make patients gain weight. They do not substantially improve wound healing or increase life expectancy. The case I was involved with, we testified, the other doctor testified. The amazing thing was the lawyer for our side, I was the anti-side, said, "Doctor, do you believe that, how credible a journal do you think the American Geriatric Society Journal is?" And he says, "Oh, those are a bunch of crocks." And he said, "What about the Journal of the American Medical Association?" "Oh, that's just a trade journal." "What about the New England Journal?" "They're clearly biased." So we lost. Amazingly, the judge said, "What can it hurt? We put a tube in, we force food in, they get better." They put the tube in, patient aspirated the following week and died. The lawyer called to share that fact with me, and I said, "Well, I certainly hope you shared it with the judge." And she had. So what do we do with failing patients? This is Joanne Lind from the AMA, same article I quoted at the start. Honest discussion, better advanced care planning, care delivery in the elder's home, and a care system that embraces long-term supportive services, medical care as equal partners. And this is telling. Food, transportation, and direct personal services are often more important than diabetes management. If you can't get to the doctor, it doesn't matter how good a job he's doing. Lastly, changes in hospice. We're seeing more patients coming to hospice. It's gone up quite a bit, but 1/3 of patients dying in hospice were in the ICU in the previous 30 days, meaning that nobody had really thought this through. We talk about, and I really and truly, I stay at the office from noon to 5 or 5:30, because that's when doctors come by and go, "Crap, I don't want to deal with this on Monday," and they refer them to hospice over the weekend. That is our busiest time when I am busily signing orders for patients coming in. And the percentage of patients dying in under 3 days has gone up. It's almost up to 1/3 now. Dr. Haim has talked considerably, but I had this slide in here. The best place to die is in La Crosse, Wisconsin. And you'll note that hospital utilization is down markedly when people have advanced care planning. So what happens to the elderly? If they go into hospice, and they usually stay home and they die. If they're elderly and they don't go into hospice, they are more likely to go to the emergency room, more than 50% in the final month. Of those who go to the emergency room, 75% admitted, almost over 1/3 of them go to the ICU, and most of them die in the hospital. With that, thank you, Reverend. Your sermon has me super excited about croaking. I'm sorry I accelerated there. I could see you.